Paul. How are you?
Good, thanks, Ian.
Thanks for joining us. So today we're going to be talking about AI for clinical decision support in southwestern Sydney. So I just wanted to start off with asking you a little bit about southwestern Sydney. And can you tell us a little bit about the region and some of the hospitals and what the clinicians get up to there, Paul?
Certainly. Southwestern Sydney is a rapidly growing, incredibly diverse area of New South Wales. It has residents from many countries, many ethnic backgrounds. I think at the last count there's somewhere around 45% of our patients who arrive in the emergency department who don't speak English as their first language. There are considerable areas of privilege, I suppose, and also greater areas of poverty and an absolute lack of privilege. So it's very diverse. It's growing rapidly. The corridor out towards the new airport means there's lots more people there all the time, and probably above anything else, it's a fascinating and exciting place to work, certainly as an emergency physician.
Great, thanks for that introduction. Now, we've recently been collaborating on a project around something called CEDRIC. So what on earth is CEDRIC?
CEDRIC is the comprehensive epidemiological database for research, innovation and collaboration. So CEDRIC's essentially a data linkage and advanced analytic platform that we've developed over a number of years. Actually started about 7 years ago with a 1-month retrospective data linkage study, trying to link emergency department data with in-hospital data, with discharge, diagnosis, pathology, radiology, all those things in a patient journey that often get siloed and separated, so that we could understand how much things happening at the beginning affected later events. That's grown since then. CEDRIC currently has approximately 25 million patient presentations, 135 million clinical documents, including discharge summaries, notes, triage notes, radiology reports. So a really comprehensive and pretty unique level of data, all of which is linked together in a patient journey. Amazing.
We recently collaborated on a project. At Fujitsu, we call that AI Test Drive. But essentially, it was about combining high-performance computing with the data that you hold locally. Now, obviously, that healthcare data is sensitive. You've got personal information, you've got healthcare information, and you also have identifiable information. So it's very regulated. Can you tell us a little bit about the inception of the project and how it came about that we wheeled this these GPUs into the healthcare environment for you?
Yes, definitely. Look, I mean, the first thing I'd actually just say here is thanks to Fujitsu, because it gave us a remarkable opportunity to do some things that are very difficult for us to have done before. It sort of arose, we desperately needed the opportunity and the ability to be able to perform this sort of advanced analytics and inference on premises. Because as you say, sensitive data, people's personal data, and despite, comprehensive ethics approval and the rest of it, there are, health, privacy and security is non-negotiable. It's something we have to ensure before anything else. So, and we needed to be able to do advanced analytics on premises because we can't send the sort of data to the cloud. And although there are, obviously in New South Wales there's the single digital patient record, which is a great thing to be able to link together, all of those sets of data from different parts. It's not complete, and there's always going to be data that is separate from that, which is part of the day-to-day running of a health service, running of a hospital, and caring for patients. This is complex, often non-linear data, things that we need to be able to analyze, but we need to be able to analyze it very efficiently and very rapidly on premises. And that really relates to data which is a patient level data, but even then data to a system level, because both of them are complex adaptive systems, and to understand them, to understand what may happen, predict what's happening or what's likely to happen, even diagnose patients using multiple different variables. These all need really rapid and comprehensive computing, and that's what the DGX box enabled us to have on premises.
Thanks, Paul. So let's dive a little bit more into the technology now. So Fujitsu brought the NVIDIA DGX technology physically to the health service, and we installed it, obviously with the appropriate security and the appropriate mechanisms for your team to gain access to it. What did you do with it? What mischief did you get up to? Because you suddenly have this toy to play with this high performance computing. What did you start off doing with it?
I think you're absolutely right about the enthusiasm part. My data science colleagues were ecstatic, of course, and trying to get them not to do things was probably the biggest problem. But look, we were able to do jobs that would have taken us, either would have been impossible or would have taken weeks or even months. So, we anonymized patient data to be able to use in various uses, but we anonymized 3 million patient documents, and we did that in a relatively short time, in days rather than weeks or months. And that's actually documents on about 400,000 patients, which we can use as a corpus to do all sorts of important things with. We developed large language models to be able to analyze actual direct patient data, look for sort of patterns within these patient data. We have been using natural language processing with it. We've been able to develop tools such as one that analyzes data to complete the Health of the Nation outcome scale for mental health patients, which is quite a challenging, quite onerous sort of set of data to collect in one place and to get right. We were able to short circuit that and do it very rapidly and 100% correct, basically. We were able to take clinical notes and pass them into more understandable non-clinical language, if you see what I mean, as well. So we took triage notes and made them understandable to non-clinical people. We were able to generate synthetic data based on our normal data, but entirely synthetic, once again, to be able to use in training and in development of other sort of AI-related tools. We were able to, one of the things that was really quite interesting is that we're investigating trauma. We're investigating specifically e-bike accidents, which anecdotally we know are increasing hugely as people, I'm sure you've seen, as teenagers whiz along the streets with no helmets on the pavement. But in actual fact, they're very poorly described. It's such a new phenomenon. So looking at the actual structured clinical record, it seemed like there were only a few of them. So we actually used our ability to really deeply analyze data, and we actually found that there were several times as many cases as we thought there were, and these cases just not recognized, which have got huge implications, everything from patient care to cost. And we were able to actually find all of these cases, which were really buried under a sea of data, which we couldn't really delve into without the DGX box. I think one of the main things, though, is it enabled us to look at data variables, look at small pieces of information which could be really, really important in somebody's clinical condition, whether that be diagnosing a patient, assessing their level of illness, or predicting their possible outcome, is made up of multiple small pieces of information which senior clinical people integrate into an overall feeling about this is what I think is wrong. It's really difficult to be able to do that without years of experience. It's also really difficult to be able to do it, in the context of an emergency department, which is always busy and noisy. And it's also very difficult for junior staff to be able to do. What we were able to use it for was to put together all these pieces of information in recognizable patterns, use the power of the artificial intelligence of deep learning to be able to put these pieces together and use those to tell us when somebody was particularly vulnerable, particularly unwell, identify the deteriorating patient, that sort of thing, when it wasn't obvious at all. And we all know that the patient journey starts when somebody gets sick or injured and ends when they recover. And every single part of that is often siloed and separated in our system. But we were able to take all those different sections, join them together and look at the impact of early problems.
There are a lot of positives that have emerged from your research into clinical decision support, and it's quite extraordinary to see things that we never anticipated at the beginning, looking at injuries from e-bikes, sepsis, patient deterioration, and even the automatic completion of HoNOS forms for mental health professionals to get compensated for those episodes of care. Now, they're all fantastic positive outcomes. What's the flip side? What was the hardest thing about this project? What was the roadblock or the thing that kept you awake at night?
To be honest, the thing that was most distressing was actually having to give the box back. No, I say that, as a joke, but it's true, because we were empowered to perform the level of analytics that are impossible, or at least extremely difficult, without that sort of equipment, without that sort of capacity. We would be performing complex analytics that normally would take us literally weeks or months, and it would take us hours or days at the most. So, and I think what it also highlighted for me is what I sort of thought to some degree anyway, and I think even more true now, there's a lot of angst about the inclusion or the use of AI in healthcare. A lot of it based on quite rational and quite real fears, but there definitely need to be appropriate guardrails. There needs to be, we need to be able to think about what's possible and what the negative outcomes may be, and ensure that we don't ever go down that route, which is what we're certainly trying to do. And we work closely with Western Sydney Uni, for instance, identifying all of the possible sort of guardrails that we want to make sure are in place. However, what it really showed me is that AI in the end is a tool. It's a tool like any other tool. And every time there's an innovation, and there's something new, there's always going to be a group of people that are a bit worried about it, and about, whether this is going to help or hinder, whether this is going to cause patient harm, whether, it's appropriate to use it. The AI discussion is the same, but just writ large, I think. I see, given the uses that we've put it to, which, as you spotted already, were pretty diverse and quite comprehensive. AI, I think, is a tool. You have to think carefully about how you use it. You have to operate in the appropriate way with the appropriate guidelines. But in the end, it enables you to perform a task that you couldn't perform before. And whether that be, and I think clearly one of the biggest things is personalising care. If I often use this as I suppose, an explanation when I'm talking to my junior docs in ED, and I say, if you have a 75-year-old man who has chest pain going to his arm and he's a bit sweaty, and he gave up smoking last year after his infarct, his level of risk is up here. You get a 17-year-old half marathon runner who's got no medical history whatsoever and doesn't take any medications with the same pain, his risk is down here. Now, you don't dismiss the possibility of a cardiac problem, but the likelihood, the probability is far less. But working out the relationships between those different elements is the key to personalised care. And that's what AI will enable us to do much more of. Clinical decision support, to be able to use vast amounts of information in a replicable, repeatable, highly accurate way, looking at all these relationships between really important things.
Yeah, the promise of AI for personalised care is phenomenal. What I'd also like to understand is, we've spoken a little bit about responsible AI and governance around AI. Talking to other health systems that might learn from your experiences, what are the key sort of things that they should bear in mind when sort of venturing into the adoption of AI, not just for research, but for clinical decision support and to implement it in patient care?
I think the essential underpinning principle has to be that clinicians and information technologists, digital health specialists, whatever, have to actually talk to each other from the beginning. And any innovation, any technological innovation, AI is certainly one of them, needs to actually answer a need that clinicians have, that patients have, because that's sort of why we're doing the job in the first place. But the problem is, and I've seen this not only in my normal job, but as an academic, but in my job as an emergency physician, and certainly as Chief Medical Information Officer, people come from technology companies all the time with the next shiny ball, and they say, look what we've done. And often it's fantastic, and you say, that's wonderful technology. I don't need it in any way whatsoever, and nor do the patients. But there's a terrible tendency to start with the tech and then somehow shoehorn it in to answer a clinical problem. And it doesn't actually do it properly. And it doesn't talk to other things, which, as we've already mentioned, is a huge lack in the system, communication between silos. But it does the job by itself not well, often. What we need to do is say, what job do we need done? What do the patients need to increase their health, to solve a problem? And then work from there and identify the solution. And I think that's probably the major learning from these sort of experiences.
Well, you certainly identified a lot of practical use cases at Southwest Sydney. I just wanted to say thank you very much for joining us today and discussing the use of AI in clinical decision support. It's been a pleasure collaborating with you.
Thanks very much.